So, all right. So not covering. All right. So basically, guy comes in, chest pain, been going on for a while. Found to have a prox LED lesion. He gets a stent. They do a right heart cath. His index is 1.2. LVEDP is 34. They shoot the LV gram. His EF looks significantly down. So now, what options do you have?
Balloon pump, so 455.
All right. So can we just do medicines, right? Index is 1.2. Can't you just put them on a drip?
You know what fax cover sheet?
I guess what are your numbers like on the A line and your perfusion exam, your lactate?
I mean, his perfusion exam's terrible. His lactate's like 6. His blood pressure is, we'll call it like 100 over 70.
And when you guys are talking about medications, what are you thinking about?
If you say dopamine, you're immediately disbarred.
I'm assuming you're already on like a good amount of norepi. If you're titrating to perfusion and not just your maps.
So, right, we can put them on dobutamine. We can put them on milrinone. You can put them on epi. Like, there's a whole bunch of meds, but that's not the answer, right? Because somebody just had a heart attack, right? What you want to do is you want to decrease their myocardial oxygen consumption, right? Like, you want the heart to work less. So medications, all of them will basically increase the amount of work that your myocardium has to do. So, first things, being first, right? There's the dinosaur, right? We could put a balloon pump in. This technology was theorized in the 60s and started coming into the practice in the 70s, and it's kind of hung around since then. So this is the OG of mechanical circulatory support. So basically how it works is, in systole, the balloon is deflated, and diastole, the balloon is inflated, and it's inflated with helium, right? And so the concept is when the balloon is deflated, it creates like a vacuum effect where it should decrease afterload, which would lead to an increase in cardiac output. And when it's inflated, right, you are basically pushing the blood in diastole back into the ventricles, but mainly around your coronaries, right? And this should make sense, right? Like, you're hyperperfusing the coronaries, you're giving them all the blood flow they want after they just had a blockage. Like, this should work great, right? And so it's basically indications for it are cardiogenic shock, severe MR because you need all the afterload reduction that you can get. If somebody gets cath, they got multi-vessel disease that's really bad everywhere. You can hyperperfuse the coronaries to quote unquote push past the stenosis, or in high risk PCI, right? So when you're talking about with the balloon pump with its cardiac output, though, you're really talking about like half a liter to a liter maximum of increased, cardiac output support, which is, basically nothing. Where you're looking for it on a chest X-ray is you want it about 2 centimeters off the left subclavian. You want above the left main stem bronchus. It should set really close, but not super duper high up in the aortic knob on a chest X-ray. And the reason why this is important is all these are basically based in place based on height. There's different companies that make them. Their height parameters are different for which balloon gets placed with which company. But if it's too big, right, it's gonna cut off your renal arteries. And if it gets pushed too high up, it can occlude, when the balloon is inflated, your left subclavian vein, or left subclavian artery, which is going to cause your, whole left upper extremity to just die. So that's why these things are important for X-rays, and to just kind of know, you can always size down, but you can never size up. So contraindications to this are anything abnormal with the aorta, regurgitation or really bad aortic regurgitation, because if you're if you're when the balloon is inflated and you're forcing all the blood flow back with really bad aortic insufficiency, you're just going to overload the ventricle. So limb ischemia, hemorrhage, strokes, but the most feared complication is the balloon leak, because that's just specific. Limb ischemia and hemorrhage are the most common. So basically, in the early 90s, there was the randomized IABP, which basically showed that counter pulsation after revascularization led to less reocclusion. This is when they were using the bare metal stents before that we came up with drug-eluting stents. When they looked at the two trials that probably matter most to us are Tactics, which was in the early 2000s, late 90s, basically showed no mortality benefit with the balloon pump plus thrombolytics for STEMI. And then one of Dr. Bong's favorite thing that he always touts out is the IAB2 Shock 2 trial, which basically showed no 30-day mortality benefit for cardiogenic shock status post MI with balloon pumps versus no balloon pump. And then in the mid 2000s, early 2000s, 20 teens, around 2014, Ranucci et al. Basically looked at patients who had the balloon pump pace for severe coronary artery disease waiting CT surgery, which basically showed there was really no change in outcomes if it was just put in for coronary hyperperfusion. So mainly, and this is going to come up because it's the waveforms that are going to be tested on your board exams, because they get to test one, some piece of medical equipment that's old, and two, they are going to test physiology or physics based on it. So that's why they love the waveforms. So the normal waveform, in the first one and the second, the first and the third, what you'll see is just a normal arterial line waveform. And in the middle, you see that, during diastole, the balloon is inflated and it's going to increase your diastolic pressure. And that's what a normal balloon waveform should look like from an arterial line. And then obviously the blue line on the bottom is your pressure waveform of your balloon pump. So early waveforms, you're like, if there's too early of inflation, instead of it being more of a mountain spike appearance, like an M appearance, they're going to run together. Basically, you're just increasing the afterload and you're increasing aortic regurgitation because you're not allowing for the aortic valve to fully have closed before the balloon is augmenting. There's late inflation where you've missed the dicrotic knocks, and basically the balloon pump is just suboptimal. It's not really doing anything. It's not helping you. It's not hurting you, but it's not helping you at all either, right? And so then there's early deflation, where you just see what you'll see is the bottom will kind of drop out of the waveform because it just deflated way too early. Again, this is where you end up getting retrograde coronary flow, which can present with anginal-like symptoms for the patient. This was the one that they'll probably give you if they're on the test question because of the retrograde coronary flow. And then there's obviously too late of deflation, where you'll get the widened appearance of the balloon, and basically there is no. It increases your afterload, just because the balloon is trying to contract the ventricle while the balloon is still inflated. So you're just pumping against a harder pressure, which is basically negating everything that the balloon pump theoretically should do. So just make sure before you walk into your board exam, you just look over the waveforms, because that's what's most commonly going to be tested. These were way more common before all these things got computer automated. With that, the machines pretty much take care of themselves, and it's really hard to actually switch one of the current generations of the balloon pump out of its automated waveform mode to more manual mode. And that's just because the computer is smarter than we are at this point. And so, but what happens, what do you do when the patient, like if they were to go into asystole and they had a balloon pump in, right? So you can switch the trigger over to the arterial pressure, and that should cause the balloon to auto trigger every time it sees some sort of arterial waveform with chest compressions. But if you can also switch off of that to control the balloon volume with an internal trigger. Basically, with that, you can just set the rate to 60, 80, and you would just set it to augment 1 to 2. These in general are really a problem because the balloon isn't necessarily or you could just put the balloon on standby and just do regular chest compressions and hope that you revive the patient.
So
if for some
real
reason
quick, why wouldn't you just put the device on standby given concern of migration while doing chest compressions?
That's probably a fair point. I think theoretically, though, with the balloon in, you could increase the amount of just overall perfusion to the body. But your point is probably the safest, is that if the patient goes into asystole and you start chest compressions, it's probably just easy to put the balloon in standby and just because I think you're going to spend too much time trying to troubleshoot the balloon and not enough time doing the things that matter, which are just good chest compressions and resuscitation. And then if there's any like, basically, if there's generally the most common things with the balloon pump, if something's not working, is you just need to run the tubing. There's in general a disconnect somewhere in the tubing if the balloon isn't like capturing, if the waveforms aren't working, if the waveforms are off and funky, it's because something isn't connected. And then the other thing would just be to make sure that it's hooked up to a power source, and that the battery hasn't ran out because it just sat down in the cath lab but wasn't charging. You can always hand inflate and deflate the balloon. I wouldn't really do that. I would just opt to switch out for a brand new console. So if it's not working, run the lines, make sure it's plugged in, and if it's all not working, just switch out for a brand new console. The big things, and this is probably one of the ones that you're probably going to get caught on a board exam, is what happens if it looks like there's a balloon rupture. So in the balloon sheath and in the helium sheath, remember these should be closed systems, right? The balloon inflates and deflates with helium, and there shouldn't be any blood in it. So if there's ever blood in the tubing down here, like on the bottom right of the image, or if you're looking at your balloon waveform and it's not coming back to baseline and it's showing a drop off in its baseline pressure, that would all be concerned that the actual balloon has been compromised. At which point you put it in standby and you've got to get it out, because it's just going to cause a ton of problems. So that's kind of it for the balloon pump. So now we've stepped into the future a little bit, and basically what we have now is we have CP Impellas, or Impella CPs, that are basically percutaneous through the groins. So these are basically just short-term percutaneous VADs, right? And the principles of VADs and the principles of Impella are basically the same thing, and its main indications are cardiogenic shock or high-risk PCI. So basically, this is what it looks like, right? You've got the controller, which is where it's got all your waveforms, and it's got the perch cassette, and it's got the controller, and then off of this comes the microaxial pump, or the Impella itself. All right. So basically, it's got on the distal end of it, it's got a little motor that basically just like it was a submarine, it's just this rotational screw, and it works. I think it's Archimedes' principle that the faster the screw turns and rotates, the higher output will be. So when you're adjusting P levels on the console, what you're really doing is, as you increase the P levels, you're increasing the revolutions per minute. The increase in revolutions per minute that the screw spins corresponds with an increase in cardiac output. But remember, all you're doing is increasing revolutions per minute, right? If there's high resistance or there's clot formation, you may have to go higher for higher revolutions to maintain the same cardiac output. But the only thing that you can change is revolutions per minute. And so the magic number to remember with Impella CPs is 3.5, because it will give you 3.5 liters of flow. And when you're looking at it under positioning, it needs to be 3.5 centimeters off of the aortic valve, right? And so basically the contraindications to Impella, it's easy to think about them from the outside coming in that if there's bad groin access, if there's something abnormal with the aorta, if there's a mechanical aortic valve, or severe AS or severe AI, meaning that the valve it's too stiff or too loose to get through to matter. If there's an LV thrombus or there's a VSD, all of these things are absolute contraindications to Impella. All right. So the complications of this are easy, because you just got to think about, where does it start, where does it go, and what does it touch, right? And so where does it start? So major bleeding, because you're shoving a 14 French catheter into the groin, into the femoral, the superficial femoral artery, right? So you can get major bleeding from the side, you can get access bleeding from the side, you can get limb ischemia from the side, because it's a 14 French catheter as opposed to a balloon pump, which is only an 8 French catheter, right? What does it touch? It touches blood, and you've introduced it through the skin, so you all can always get sepsis, and you can definitely get hemolysis as this screw is turning and churning up the blood. And then where does it go, right? This thing can always migrate or malfunction, going further into or out of the ventricle, or overcoming some of the valves, mainly the aortic valve or the mitral valve. So those are the main complications of these, right? And so the evidence to be honest with you, the evidence for this in randomized trials is severely lacking, right? So Protect 2 was the only actually randomized control trial that looked at Impellas for high-risk CP, and basically it showed no difference in 30-day major adverse events with the Impella 2.5 versus the balloon pump. And then Protect 3 was a prospective non-randomized trial where they basically started using CP Impellas for some of these higher risk PCIs, mainly when they're stenting the left main. And then it showed a reduction in all major cardiac events. And then if you look at Impella's quality database, which includes the Europella and the USPella databases, those databases show benefit. But again, it's in a non-randomized fashion. So Protect 4 and STEMI DTU, which is basically looking at putting an Impella in before doing PCI, whereas and then Protect 2 is looking at that on a slightly different riff. Those are currently enrolling, so we should have that data in the future. For cardiogenic shock, there's only ever been one, and that's the ISAR shock trial in 2006. All of these, that's the only one that's ever actually been completed. It was non-randomized. All the other ones have the trial never even finished because of low enrollment. And what it looked at in ISAR shock was that there's better cardiac output with a 2.5 Impella versus a balloon pump at 30 minutes. Like, that was the primary result. Like, and that's like a non-patient centered marker. I don't even know what to do with that. And if you looked at it, and it was only, I think, a total of 19 or 20 patients, and the mortality was the same in both groups, which is about 40%. The danger shock started enrolling in 2012, and I think is still currently ongoing. And then Recover 4 is also currently enrolling. So it's just hard, I think, to get a lot of patients in like these big shock trials, just because not enough centers are super duper aggressive and will just fall out of the criteria. So low enrollment has been the problem. So basically we're going off of single center studies and some of like maybe the major, more larger institutions that use these. So Shock data and their single database coming out of Northern Virginia showed better 30-day survival with a team-based approach, which include intensivist, advanced heart failure, and CT surgery. One center looked at and showed a lower 30-day mortality with a CP versus a balloon pump after PCI. One study that was I think a European trial looked at their observed mortality was better with Impella compared to the predicted mortality. So basically, when you come into an ICU, everybody's got a predicted mortality, and our goal is to beat the predicted mortality on all of our patients. So that would be what your observed mortality is. And then the National Cardiogenic Shock Initiative, this is the Henry Ford database that everybody talks about. I think it came out, 2021, and they showed a 71% survival to discharge with greater than 90% recovery of your native heart function. And that was with aggressive implementation of these of the Impella CP. So basically, if the overall predicted mortality of these patients in cardiogenic shock when they hit the door is 40 to 50%, and they're saying they got 70% survival, they basically drop mortality 10%, which would be astronomical. And basically the same thing with a Japanese database that looked at all of their major tertiary care centers. They showed a 77% 30-day survival rate. So that would be even a little bit better than what the Henry Ford database showed. So the overall consensus of these things are they probably help in really good centers that do it often. And there's no good randomized data to tell us if we should use them across basically all sites. So if you're looking at Impella CP complications.
So I just want to add real quick. I think Jared is really important, like in the last slide you showed, just to clarify that all that amazing data was only for acute MI cardiogenic shock, not for non-MI.
Correct. This is all acute MI cardiogenic shock. The high risk PCI data out there, it doesn't. It's iffy at best. What the data that's not on here though is that there's a big debate right now. And then do the PCI versus do the PCI and see if they need the Impella. And the concept behind this is when somebody's got, like, let's say they got a left main or a prox LED, or they're left circ dominant or right circ dominant, and they've got a really proximal lesion in the main artery that's supplying all the blood flow to the heart. The second that they balloon open that blockage, right, you basically completely occluded the main artery that's supplying all the blood flow to the heart. And yeah, I mean, the balloon's only up for a couple of seconds, but in somebody who's already compromised, that those little bit of seconds can just send them down an absolute spiral, right? Because for those couple of seconds, they don't have any cardiac output. So if you put the Impella in and the Impella is running, the ventricle is going to be offloaded and you're going to have cardiac output and you're going to perfuse your other coronaries while you're ballooning open the obstructive lesion. So, I think there's basically some studies that show some single center or some single, database study showing that they have better results with putting an Impella in first, which is why there's now all these big initiatives with these randomized control trials to say, hey, in these, sick patients, maybe we should put the Impella in before we try to go and, and open up the lesion. That data is not on here, but it's out there in the literature if you look for it. All right. So complications. One, these things can always migrate. So best practices are general, put them in a leg immobilizer. Make sure that the Impella, on the end of the Impella, there's a TUI lock. Make sure it's locked. A lot of times the interventionalists will put these in and then forget to lock the TUI. And then they get pulled or moved as they're going from the cath lab table to the ICU bed, or vice versa if you have to take them down to CAT scan. So leg immobilizers help, especially on patients who are non-intubated, just to make sure that they know that they have to keep their legs straight. Because the second they bend their knee, they push and pull the Impella, right? So how basically Impellas go in is wire goes in, needle goes in, wire goes in, needle comes out, dilator goes in, wire comes out. And so the dilator that you see in the middle of the picture is the dilator that stays in. And then they take a J wire and run a small J wire all the way up under fluoro and put it into the ventricle. And then they take and attach the actual Impella device onto that J wire, and then the J wire runs. They railroad the Impella over top of the small J wire, and that wire comes out another side port on the Impella. So once the Impella is in place, they pull the wire out, and then the Impella is left in with this breakaway sheath. in people who have never put these in or don't put them in frequently, they may forget to remove the breakaway sheath. And that becomes a problem because it wasn't meant to be there, and they will hemorrhage around this breakaway sheath. So the sheath in the middle it peels off at both sides, and it should just peel away. And then what you get is the actual nub of the Impella, where you can suture it, and you see it sutured in a forward fashion, meaning they are always throwing and pulling, trying to pull the Impella into the artery in the skin. And so you want them sutured in a more forward fashion. And then with that, you have to set these up a little bit. They should be about 30 to maybe 45 degrees. And what you're really doing is just trying to prevent, because most of the times when these things bleed, they bleed around the insertion site, just because the dilator hole is bigger than what the Impella is. And so you just need it kind of hubbed all the way up in there and tight. Otherwise, you'll just continuously ooze around the actual Impella. And then just make sure, ACT needs to be like 160 to 180. These patients got bolus with heparin a lot of times, so there may be some bleeding in the beginning just because they're just super therapeutic with the heparin. So with limb ischemia, remember that these are 14 French catheters that are setting in there. So if the vessel size is less than 55 millimeters, or your sheath to artery ratio is basically less than 1, then you have a decreased risk. So it's got to be a big artery, bigger than 55, with a ratio of less than 1. If it's the other way around, they're at a high risk. And actually, if it's under 0.5, you're basically excluded from getting a CP Impella. And then obviously age, extremes of age, and then body habitus. Extremes of body habitus, like low BMIs as well as high BMIs. And then prior bad vasculature. Is it placed under emergency? Did the interventionalist use an ultrasound? Is there a venous sheath right next to it? All of these things increase the risk of limb ischemia. And then obviously antiplatelets and anticoagulation can help. There's no distal perfusion catheter on these. You can put an arterial sheath in the contralateral leg and run it up and over and across, and then stick distal to where the Impella is inserted. I've seen that done once before, but typically if there's ongoing ischemia, you'll just pull the Impella. So hemolysis is going to be the biggest complication that you're going to run into. And the answer is you got to optimize PAP, and you got to have close monitoring. So you want plasma-free haptoglobin. Most centers don't have that, just because it's an expensive test. So you're going to be using your regular haptoglobins and your LDHs. The problem with that is LDH is an acute phase inflammatory reactant. And so in somebody who's in acute MI shock, that LDH can be through the roof. So you're going to have to really look at the urine, look at what your haptoglobin is doing, and trend the LDH more than taking the LDH in an isolated value. So by optimize the PAP, what I mean is you got to optimize your preload. So not all of these need to have a stupid high preload. Like you don't have to target a CVP of greater than 10. If the thing is flowing just fine on P8 or P7 and your CVP is 6 or 7, then don't touch it. If you start getting suction alarms and your CVP is low, you should target a higher CVP, just to make sure that the thing is, because these are preload dependent and afterload sensitive, right? So if you ever have a drop or everything is going fine, and then all of a sudden you start, you see your CVP go down, be worried about a bleeding event. And then also you have to constantly be making sure that the patient didn't go from isolated left-sided failure into bi-V failure. So again, these are afterload sensitive. So you want to target, 60 to 80 of a MAP. And more important than that, you want to look at your systemic vascular resistance, right? So this is the urine on somebody who has a stupid high SVR of, around 2,400 versus a more normal SVR of around 1,300. And obviously you can see the difference in hemolysis that was occurring in the patient. So you'll basically, if this is happening because your SVR is really high, on a P8, P9 flow in the Impella, you should be expecting, 3.2, almost 3.5, like full support from the Impella. If you're all the way that high and you're only seeing cardiac output or cardiac Impella flow of like 2.8, that may be indicative that your SVR is just way too high, and you may need to add some drugs to kind of lower that SVR. And then positioning.
So in that case, can you also rely on your billing?
Say that one more time.
Can you also rely on the bilirubin, your direct billing?
Yeah, you can, absolutely. I mean, all the bilirubins, all of those should go up. The question though, and yeah, the direct billy would probably be great within the first day or so. The problem is, like, all these patients are going to end up with ischemic hepatitis. So by the second or third day, your bilirubin may be going up, just because of the liver injury that occurred, and might not be an actual marker of ongoing, like, worsening hemolysis. It's probably, I mean, it's gonna be hard to tease that out acutely, absolutely. But once you get too far down the road, it's gonna be mixed. And so the next thing is positioning. So when you watch these Impella videos, right, they give you the most pristine placement of the Impella possible, right? So what you're really looking for is you need to see the inflow tract of the Impella and the aortic valve, right? And so what that looks like is you'll have, remember, these things come with a on the bottom left screen, they all come with a pigtail catheter. And then you'll see that the right next to the right where the pigtail catheter is entering the Impella is the teardrop, because it's like this little metallic piece. And then after that is your inflow. So that's what you're trying to identify under echo. So sometimes it's easy to find the teardrop or to find the pigtail and then trace it up to find the inlet. And then the aortic valve is always generally easy to identify. And remember, the distance from the inlet to the aortic valve, you want it to be at least 3.5 centimeters, right? And so if it's hard to see, like in the picture on the left, the inlet valve is clear as day, easy to see, right? Like nobody's, and that's what the Impella training videos give you, right? So in the picture on the right, though, it's a little bit more muddled. It's kind of hard to see exactly where it is, but these things will have a ton of turbulence at the inlet with Doppler flow. So sometimes you can just put color flow over the tip of the Impella, and it will give you a better sense of actually where the inlet is and for you to get your measurements, right? And so there's a pressure signal inside of the aorta, and then there's the microaxial sensor that sets outside. And so what this really does is, how this thing generates your LV waveform is it takes a difference in pressure across the two monitors, and that's what generates the white value down there. The red value is just generated off of an arterial line. So this is basically what a normal, normal function Impella should look like. And then because the signals have to be generated with differences across pressures, the two most common or the two most easy to diagnose waveforms are when they're flatline, right? With the motor current, there's no current going across because the sensors are in the same place. And so in this one, your LV waveform looks like your aortic waveform, which is indicative that the Impella isn't in the ventricle at all, right? Both the inlet and outlet valve are just still sitting in the aorta. And then on the next one, the arterial waveform looks like the LV waveform, and that's because it's too deep, right? And so if your motor current is ever flat, you need to say that both of the sensors are on the same side of the aortic valve, whether it's too far out or too far in. In this case, you would just put the ultrasound on and pull back. In this case, this is when you're calling the interventionalist to come back, because it's hard to advance that pigtail catheter through the aortic valve. And what you don't want to do is push this thing in and cause, damage to the aortic valve, in which case now the Impella doesn't help you at all. So this is the one that's going to be the most tricky to identify. And because your motor current is flat, I don't know what to make of that LV waveform, and your aortic pressure line is flat. And so this can either mean two things. And in the old, before the Smart Assist Impellas came out, this used to just pop up as a big question mark on the Impella device itself. And so this is basically showing this can either be a malpositioned Impella, in which case you just need to reposition it under ultrasound, or B, the patient has such low cardiac function that the native ventricle is unable to generate a pressure difference for the two separate sensors to monitor. So this could just be either A, malpositioning, or B, really bad native cardiac output, in which case you can either A, put them on some drips, or B, just wait out and hope for native heart recovery. And then the last thing we'll go over really quick is suctioning. This is going to be the bane of your existence with these devices. So basically, a suction alarm pops up on the Impella. And what you got to do is A, you just reduce the P level. So if you're on P8 and you're starting to get suction events, maybe it's just running a little bit too high, and you can drop it down to like P7 or even P6, and the Impella will just start cruising along again. But then you got to go hunting for why it caused that. Why did that happen in the first place? So these things can basically get suction events from three different problems. One, at the inflow, because it's against the valve wall, or it's against the mitral valve, or your preload is too low. Two, you develop a clot within the cannula itself. Or three, there's obstruction of the outflow valve because it's setting right on the aorta. It's just too deep. So in the inflow problem, it's positioning. Is it a volume issue or preload issue? If it's a clot within the cannula, your purge alarms are going to be off. And then if it's, you should be able to find these out, figure this out generally easily if it's an outflow tract problem, just by putting the probe on the chest. So with the Smart Assist, there's two different kinds of suctioning alarms that occur. There's a diastolic suction alarm. And so if you zoom in, you basically see that the LV waveform does recover from the negative pressures. It ends up looking like a normal LV waveform on the left side in the white. Your diastolic flow will be low, meaning the bottom number on there will be low, but the top number, the 3.8 liters, will still be fine. So this is basically optimize your pressures and check the positioning. This is mainly always almost a volume issue, whereas continuous suction events, right? The diastolic pressure doesn't recover. You don't get that nice overlap of the aortic pressure and the LV pressure. Aortic pressure remains above the LV pressure, right? And in this case, both your systolic and diastolic flows will be lower because the Impella is constantly suctioning. It wasn't able to recover from it. And this one is, if you'll see this alarm, and this one should start scaring you if your CVP is 10 or 12, and you're starting to get these alarms, because it mainly shows that your RV is also starting to fail you. And this should correlate with a downtrending PAPI, because all these patients should have Swan-Ganz catheters. And then the forgotten component is the purge. Basically, the purge is, this heparinized glucose solution that sets a couple, 300 to 1,000 milligrams of mercury above what the systolic blood pressure is. And this is basically because you want to put enough pressure against the blood that's going across that Archimedes screw, so that it doesn't clot off the motor. And so if there's excess pressures, this is concerned that a thrombus has developed within the center of the catheter itself, versus low pressures. It's generally that there's a disconnect in one of the tubing somewhere. But if the purge pressures go really high, acutely, you can distill a small amount of TPA into the purge solution, and it's on the magnitude of like 0.04 up to 0.08. And so two different places looked at this in very small case series, the Mayo Clinic and VCU. Each of them went between like 0.02 all the way up to 0.08. I think the most commonly accepted is 0.04. You distill it in, and it should resolve things within a matter of 15 minutes or so. I've always went with the 0.04 dosing, because you can always redose it if it doesn't work. And then there's in the small case series, there's just higher risk of hemorrhage when you use the higher dose of the 0.08. But I mean, I think these case series was like, between both centers, was like maybe 10 total patients. So there's all my references, questions.
So you kind of flew through the part about the negative diastolic pressure. Can you go through that again a little slower? One with the continuous suction.
Yeah. So basically, with this, the LV waveform will be the same, right? The LV waveform will recover in diastolic suction events, and the only thing that you'll ever see, because it recovers, your systolic pressure will remain normal, but your diastolic flow will be less. Versus with a continuous suction event, the LV waveform does not recover. They don't overlap. There's no overlap between the LV waveform and your aortic waveform, and that's just because this is a constant low flow issue. And so it can be, you can see these coming out right away if the patient's massively underfilled, or maybe the Impella's in a little bit too deep and it's just up against the wall or something like that. So in those instances, you'll see constant suction events. More commonly, you'll get diastolic alarms first, because you're just a little bit behind. And if you correct the positioning or the volume status, mainly pushing the CVP above, to around above 10 or 12, the issue should resolve. But in continuous suction events, if it happens down the road, a couple hours into the Impella being placed, it's in good position. Your CVP is still 12, but you're getting these constant suction alarms. It's because the RV has failed.
So in that previous one, how come your aortic pressure is lower than your LV systolic pressure?
It's just, I mean, the examples of the actual LV, the aortic pressure, that's like tomato. That's
Okay,
not
'cause
as
I don't think that would
important.
be an issue with like positioning, or are you only relying on the diastolic pressure?
Sorry, that was a lot, and I flew through it. I just felt like I was behind because we started a little late.
No, that was great.
Yeah, and then just a reminder, next week we'll actually have the Impella rep come in with an actual device, and then we'll kind of go over more of the troubleshooting patterns that we can see. Jared, one of the issues that I see a lot is that if an Impella device gets placed in the cath lab, and then they bring them up to our unit, that's when majority of the problems will happen, if they're going to happen. One of the problems I commonly see is, usually an issue with positioning and with bleeding. Some of our obviously more experienced guys will make sure that they've taken that second catheter out. But what I'll see is that, with patient positioning, there's sometimes aware, and it's not as often involved. What should we do that's fair to troubleshoot it or to make it in addition to quality intervention?
So if you actually, if you look at the if you actually look at like an Impella, you see there's like right almost where that center arrow is, there's a hyperlucency area just to the right of it. So when they're putting these things in the cath lab under fluoro, all they see is they see the pigtail, and they kind of have a relative working idea of where the aortic valve is, and they try and match that ring up to set right on the aortic valve. And so that's how they are seeing it when they're putting it in, to know that if it's in position or not. Sometimes they don't use the Impella wires to get them in. They'll use a smaller wire. And you see how the Impella has a natural bend to it, and the natural bend should bend down and flow into the LV cavity of the ventricle. Sometimes these things are flipped over and reversed, in which case the curve is going away from the natural curvature of the ventricle. Those are the two most common problems, is that it's not following the natural curvature, or they got a little bit too deep when they are trying to gauge where exactly the aortic valve is in relation to the hyperdensity on the Impella that they're seeing under fluoro. They almost always put them in too deep, unless the patient has a really small ventricle, in which case from either A, just this severe LVH, or B, sometimes in women who haven't had longstanding hypertensive, issues and don't have any sort of like dilated cardiomyopathy, sometimes the ventricle is just too small to physically get one of these in really good positioning. The bleeding issue, you just got to make sure it's up at 30 degrees and is sutured forward, and just make sure the PLOA sheath isn't there.
The issue I've seen is usually with patient positioning is like when they get transferred from bed to bed, they'll change the angle of their leg, and then somehow like once the that's done isn't good enough, and then they'll have to do it yourself or call there, just have to adjust the angle to make sure that it's
Yeah, it's generally because the angle's too shallow, or it's not sutured forward tight enough. And you can just throw extra sutures in to make sure it gets pulled tighter against the skin, and then make sure that the angle is more appropriate, like that 30 to 45 degrees.
Awesome. And then just last question, more for the first years. Can you just speak on the anticoagulation for both devices?
Yeah. So the answer is you don't actually, patients don't actually have to be on systemic anticoagulation. Sometimes you can get by with just heparin in the purge solution. If for some reason you're not getting high enough ACTs with that, what you would do is you can just put the purge into a bicarb solution, and then just put them on systemic anticoagulation. It becomes hard for the nurses to actually adjust the heparin, because when you put in heparin in through the purge and then you start systemic heparin, what ends up happening is they end up dripping like 1 cc of heparin in to the patient. It's a very, very teeny tiny amount of actual systemic anticoagulation that they need for the adequate ACT. So sometimes it's easier just to put the purge in bicarb, and then just to start them on systemic heparin for the targeted ACTs, because then the nurses aren't having to calculate the purge plus systemic. They can just do one calculation to send down to pharmacy. And then obviously if there's ever a concern for HIT in patients who, maybe, were on heparin for a while and then got worse and now you don't know, you just empirically put them on bivalirudin. There's no role for argatroban for systemic anticoagulation with these patients. It's either heparin or bival.
Awesome. Thanks, man.
Jared, what are your thoughts on the evidence behind heparin versus bival? Are you about bival guy?
I'm a bival guy just because one, the only reason we don't use it is because it's just more expensive. But it takes all of the, because all these things are always focused on HIT. And we've had, I think, 2 patients who developed HIT with these devices, and then you're really SOL when these people start to bleed, because they have to be under some sort of systemic anticoagulation, or they're just going to clot everywhere. So my personal preference is to put them all on bival, because I think you take away all the serious, like, bad downstream complications, and you have the same risks essentially, except that bival comes with a shorter half-life, assuming your kidney function is normal. I think the half-life of bival is like 15 minutes, assuming normal kidney function. What do you think, Mike?
Sorry, I got kicked off for a couple seconds. But generally, I think the vibe I was getting from you was that you think bival is probably the way to go.
Yeah.
I think the evidence definitely points in that direction. I would definitely favor using bival over heparin in these patients. Actually, almost anyone on mechanical circulatory support. But Dr. Ward, that was fantastic. Thanks so much.
All right, and so hopefully this, seeing this now and then seeing it again with the Impella in service, it's the waveform. It's going to be the waveform and practicing positioning with an ultrasound. So if you see it once and then see it again, hopefully that'll help you guys. So if you have any questions, just let me know.